Hi, welcome everybody. I'm Tony Mancini. I'm a pediatric dermatologist in Chicago, and today I'd like to speak to you about the evolving clinical landscape of scabies. Scabies is an infestation that you're all familiar with, and really it can be much more than just a nuisance. It's caused by infestation with the scabies mite, Sarcoptes scabii, and this mite burrows into our stratum corneum just below the superficial layer of skin, where it lays eggs and feces. This then incites an inflammatory response, and we get this hypersensitivity immune reaction that results in marked itch. This can really have an impact on quality of life. The transmission of scabies is really by skin-to-skin contact. So as opposed to lice, another common infestation in children, fomites don't play nearly the role with scabies that they do with that condition. Now, in the United States, we really lack a credible source for reporting the prevalence of scabies. But if you look at prescription data in our country, it appears that nearly 1/3 of all prescriptions are written for children under the age of 18 years of age. Scabies can be a source of a lot more of morbidity and social distress. These patients don't sleep well. The families may not sleep well. It's very contagious, person to person. So households are frequently all infested. And this really can have an impact on quality of life. There can be an associated severe pruritus, which can be chronic when it's underdiagnosed. And so we have to really consider this impact. And keep in mind that some literature has suggested that the quality of life impact may be similar to that of chronic pain syndromes. This cartoon just shows the scabies infestation. These yellow creatures are the mites on our skin. You'll see how they burrow under the stratum corneum. And right there is where they develop this tunnel in which they may deposit eggs and feces. And that then propagates the infestation when new mites are hatched. So this is a very intensely itchy eruption. Patients develop papules, vesicles, nodules, and remember that scabies can present in different ways. So if you look at the blue box on the right, the classic presentation of scabies, which is the most common form, is those patients presenting with severe itch. They may be tired because of sleep disruption. They tend to have a lower parasite burden, and they have the very characteristic features which we'll look at in just a minute. The crusted form of scabies, also known as Norwegian scabies, is a form that we see typically in immunosuppressed patients or those that may have neurologic compromise. This is a form where you have a very high parasite burden. One scraping, we can see 10s, 20s, 30s, sometimes hundreds of mites under the microscope. This can be associated with lesions that aren't characteristic for scabies, so it's often misdiagnosed, and hence it can be spread very easily. One example is among long-term care facilities. So these burrows are formed as the female mite burrows in our skin. Remember that they then lay down the eggs, which hatch into new mites. And the itch with scabies tends to be worse at night. Here's some pictures showing the typical lesions. If you look at the left panel, that really shows the linear burrows you can see in the web spaces on the hand. The middle panel shows that hypersensitivity, very papular eruption. And on the far right is a really sine qua non of scabies, which is any erythematous papules on the penis of a male should be considered scabies until proven otherwise. Now, there is a typical distribution pattern. Think about fingers, web spaces, wrists, elbows, knees, the groin especially, genitals, especially the penis in males, as well as the belt line and the axillary regions. And then in females, the nipples, the areola, are really common sites of involvement. In infants and young children, one area I always teach fellows to look at is the palms and the soles. Crusted papules on the palms or soles in a child is scabies until proven otherwise. Infants and children also get involvement of their scalp, their head, their face, their neck, which is much less common in older patients. So always think about those areas of involvement. And then in the blue box, you see nodular scabies. This is a form of scabies which tends to be unique to children and mainly younger children, infants and toddlers. And this is where they develop a really vigorous host immune response against the mite. This results in very itchy and very persistent erythematous papules and nodules. And you can see several of those nodules in the photographs I'm showing you here on the bottom of the slide. If you look at the photograph on the far right, the lowermost lesion, you see a red flare around the nodule. That's a pseudo-Derrier sign. Many of you know the Derrier sign is something we look for in mastocytosis, but with some patients with scabies nodules, you may have a positive Derrier sign as well. Other images from the pediatric world. So here you see palm involvement, and notice that you have a lesion right there in the fold of the palm. So for those of you who may do scrapings for diagnosis, we'll talk about that in a minute, going for the natural creases of skin is going to be a higher yield if you see lesions there. The mite kind of falls in to that little crevice. The foot on the upper right shows you multiple linear burrows, as you can see. And on close-up of the hand in the lower right corner, again, you can see multiple linear burrows. Remember that the mite is at one end of that burrow, and scraping through that burrow is one of the highest yield areas we have for doing mineral oil scrapings on the skin. Here's a prepubescent boy, and you can see on the penis, he has erythematous papules and nodules encrusting on the distal penis, on the foreskin, and on the glans penis. So that is scabies until proven otherwise. This also reminds me that a really common location for scabies nodules is the scrotum. So if a baby presents with firm red nodules on the scrotum, think about scabies nodules. Even though we have an accepted practical system of diagnostic criteria, it's not really used by many practitioners, and that includes all specialties. So this diagnosis can be challenging, and often it might be delayed. So let's look at criteria for diagnosis. First off, we just talk about the clinical presentation of scabies. We just looked at the clinical lesions and the classic distribution pattern. Hopefully that will bring you close to making the diagnosis. I always joke with my trainees, this is an across the room diagnosis. When I walk in the room and see that infant on the table with these very polymorphous crusted papules on exam, and maybe a parent who's sitting next to them scratching their wrists, we know we have the diagnosis of scabies. We'll look at the burrow ink test and the topical tetracycline test, and then we'll look at other confirmatory testing, including light microscopy images and dermoscopy, which I realize many of you may not use. So physical examination and history is very important. Think about itch, ask about family members in the household, because again, this is highly contagious. Look for that papular or papulovesicular rash. Crusted papules are really very significant for scabies. These two photographs show linear and serpiginous burrows on close inspection. You may not always see burrows. They're not needed for the diagnosis, but if you do visualize them, it's really a slam dunk for the diagnosis of scabies in most cases. Remember that infants are more likely to have involvement of the head, the face, the palms, and the soles. Always look in those locations. This is the burrow ink test. It's something of historical significance. I will say it's rarely performed now by dermatologists, and even more rarely performed by family practitioners or primary care pediatricians, but it is very useful. This is where you take a washable marker. We would use the purple surgical marking marker that we use in the clinic, and you go ahead and rub over several areas that you suspect might be scabies lesions. Then you wipe off that ink with an alcohol prep, but the burrow is going to preferentially take up that ink, and you're going to see a linear or serpiginous burrow, as you see in this photograph on the right. This can be very useful for those who have fewer lesions or where it's more difficult to visualize the burrows, but for some clinicians, it's not practical. Topical tetracycline is something that I think even those of us who are dermatologists have less experience with, but it was a historically very interesting diagnostic test. This is where you take a tetracycline solution and rub it on the skin in these suspected areas, and then you use your Woods lamp, the same Woods lamp that many people used to use for diagnosing certain forms of tinea capitis. And you'll see a fluorescence that's a greenish color in areas where you have that tetracycline taken up into a burrow. Again, this is seldomly performed by either dermatologists or primary care physicians. The real confirmatory testing we like and still perform is that of light microscopy. And I realize that many of you as primary care physicians may not have microscopes or may not have time to really do these tests in the clinic, but important to know how this is diagnosed in a specialty clinic. The way we do light microscopy, though, is with the mineral oil preparation. This is where you take a drop of mineral oil, you put it right over a few lesions that have been identified to be ideal, like linear burrows. You scrape right through the oil with a number 15 blade. You do tend to draw a little blood when you do this test. You then smear that on a slide. I add a few more drops of oil to that slide and look under low magnification in the light microscope. The beauty of using oil is that the scabies mite is still alive. They're not killed by this reagent, so you can usually see them moving. You can also look just for eggs or feces. And if you see any of those three, you've made the diagnosis. I'll show you pictures of those three in just a minute. This can be somewhat invasive, as I mentioned, for a flailing or moving young child. I told you that you do draw blood. This can even be a little bit dangerous. You have to be careful and be experienced in performing this test. It can also be more time consuming, which for busy primary care practices isn't always available. It really depends on the experience of the person who's doing the test, much like a radiologist reading x-rays. So you have to select appropriate lesions, and you have to be experienced in doing the scraping to have a high yield. But it is the test that we use in our clinics. And then dermoscopy is something that those of you in primary care would not be using, but you should know about. A dermatoscope is a magnified light device that's kept in the pockets of pretty much every dermatologist now because they're used for getting a magnified look in the clinic at melanocytic lesions, nevi, moles. However, it can also be used for a variety of other disorders, and scabies is one of those, where if you use the dermatoscope, you can see what's been called the delta wing with the contrail sign. The delta wing is the jet formation that is what the scabies mite looks like under dermoscopy, as you can see here in this image. And the contrail, the plume left behind of smoke that you see with a jet, is the linear burrow you can see in the skin. So this can have very high sensitivity and specificity in the right hands. Again, this technique is pretty much limited to dermatologists. Now, there are diagnostic criteria for scabies, so important to know this. You can see the table on the left shows these diagnostic criteria, and these were criteria that were designed by a group called the International Alliance for the Control of Scabies. You can see you can make the diagnosis of confirmed scabies with at least one of those top 3 findings listed as A1, A2, and A3. So that's seeing mites, eggs, or feces via any of several different techniques we just discussed. Clinical diagnosis of scabies can be confirmed if you have at least one of those B criteria: burrows that you see, typical lesions on the male genitalia, or typical lesions in a distribution with 2 features on the history, which we'll get to in a minute. Suspected scabies can be diagnosed if you have either typical lesions in a typical distribution and 1 historical feature, or both historical features with atypical lesions. And those historical features, which are so important to the diagnosis of scabies, are itch and a positive history of contact to somebody known to have scabies infestation. So the aims of these criteria were really to provide improved consistency and standardization of the diagnosis of scabies in our clinics, and that maybe these could be used also for research studies, both clinical and basic science research, and in public health settings. A systematic review of diagnostic methods that are used by physicians, and especially those in therapeutic trials for scabies drugs, found there's really wide variety and there's no uniformity in the diagnostic methods utilized. Now, this photo in the right lower corner shows what we might see in the clinic when we're looking under the light microscope after a skin scraping, after a mineral oil prep. And you can see here on the far right a beautiful example of the scabies mite. And then following her are multiple eggs. Those are those larger ovoid structures, as well as clusters of scibala. Those are the fecal pellets, and those are all those dark concretions you see adjacent to the eggs. So seeing any of those on a prep would be considered positive for scabies. So scabies is a disorder that really is marked for low rates of immediate or sometimes correct clinical diagnoses, especially among physicians or clinicians who have less experience. And there can be barriers to confirming a diagnosis. We just discussed several diagnostic methods, but many of them are not all that relevant to primary care practices, especially busy primary care practices. Some clinicians may lack a microscope within their practices, and there really is a lack of an accurate, objective, simple diagnostic test for scabies. We don't have that yet. It would be great if we did. Then again, making an accurate diagnosis is really most important if we have safe and effective treatment options. So let's pivot over to treatment and talk about treatment for scabies. And do the therapies that we've been using for many years meet the needs that we all have today? So what are the therapeutic options? Well, number 1 on this list, over-the-counter products in this country really don't exist. There are no FDA-approved over-the-counter therapies for scabies. But let's talk about Permethrin 5% cream, the current standard of care in this country, oral Ivermectin, which has been used off-label, and Lindane lotion and why it's not used too much. So as I mentioned, there really are no tested or approved over-the-counter therapies for human scabies. Permethrin 5% cream. Permethrin is a synthetic pyrethroid insecticide, and it's considered the first-line standard therapy for scabies in the United States. People have liked permethrin because it's both scabicidal and ovicidal. So it kills the live mites, but also kills the eggs so that they're no longer viable and they cannot propagate the infestation. Permethrin is approved in a 5% cream in infants 2 months of age and older, and generally it's pretty well tolerated. But it's important to understand that permethrin, like many topically applied medications, does result in systemic absorption. I'm going to run this little video cartoon and walk you through this. So you can see here, permethrin is applied to the skin. It's the white dots. You see the scabies mites up there. It then penetrates through the skin, enters the dermal capillaries, where it now is in the systemic circulation. Because it's very lipophilic, permethrin can deposit in fat-containing organs, and those include the brain, the lungs, the heart, the liver, the kidneys. Now, fortunately, permethrin is fairly well metabolized in the human body, So toxicity is pretty rare unless it's misused, overused, ingested, etc. There is some data that suggests that resistance to permethrin for scabies is increasing, especially in certain parts of the world. So something we have to keep in mind. Lindane. Lindane 1% lotion is FDA approved for scabies, not recommended as a first-line therapy. And in my experience, it's an agent that many of us just simply do not use any longer. This is a topical organic insecticide. It's also known as gamma benzene hexachloride. And it's FDA approved, but it's second-line therapy. In fact, Lindane, because of neurotoxicity concerns, has been banned from use in the state of California for many years, just to give you a sense of how we view this agent in this setting. It tends to be less effective than other therapies related to its resistance. And let's look at this video cartoon of Lindane. Here you see the drug being applied topically, large amounts, it's very lipophilic, absorbed into those capillaries, entering the systemic circulation again. And again, because it's so lipophilic, can deposit in fat-containing organs. The organ of most concern has really been the brain, because neurotoxicity has been observed after treatment with Lindane. It should be remembered that Lindane is poorly metabolized by the human body. Hence, these fat stores may remain for much longer periods of time. So Lindane is not an agent that I'm in favor of using for this indication. Ivermectin. Ivermectin is an oral macrocyclic lactone antibiotic that has broad spectrum of activity against nematodes and arthropods, so it's good for infestations. Now, its primary use in humans is onchocerciasis, the disease that can result in river blindness, and strongyloides. It has been used off-label, though, for scabies, especially Norwegian or crusted scabies. That form we looked at earlier, which is more hyperkeratotic, more chronic, it's seen in immunocompromised and neurologically compromised patients, and can be very difficult to diagnose as well as to treat. Ivermectin has been shown to have comparable efficacy to permethrin. Generally, it's well tolerated, but remember, it does enter the systemic circulation right off because it's given orally, and it can result in hepatotoxicity as well as cardiac toxicity, especially in patients at the extremes of age, so either the elderly or young infants. It's not recommended in infants who weigh less than 15 kilograms. And let's look at this animated cartoon. Here's an individual who's taken ivermectin orally. You see it breaking down in the intestine and then being absorbed through the intestinal wall into the systemic circulation. There, it has to be distributed now back up to the skin, right, in those dermal capillaries, where it has to diffuse out. It will find its way to the sebaceous glands because they're very lipophilic, and then will be secreted onto the skin surface from there. So it really has to take its time to get to the skin surface. Then the scabies mite has to take up sufficient ivermectin for it to kill. So this is a treatment option that surely can be effective, not approved for this use, and there is some data suggesting some clinical resistance developing to oral ivermectin. It's been more than 30 years since a drug was approved by the FDA in this country for scabies. So our treatments really haven't evolved as we have increasing understanding of the disease and increasing understanding of the limitations of our currently available therapies. Why is control of scabies so difficult to achieve? Well, we've discussed several today. There can be a delayed diagnosis or a misdiagnosis altogether, which then is going to propagate the infestation to close contacts. Inappropriate medications may be used, or we may prescribe the right medication and it may not be used correctly by the patient. It could be overused, it could be underused, or maybe they're not treating all their close contacts as instructed, and that's when we get into the trouble of reinfestation, which is a real problem with scabies infestation. Also, we have to consider resistance of the mite to the existing products we have available to us. This quote by Gopinath in 2018 is really very accurate. The existing scabicides have variable drawbacks, including toxicity, adverse events, limited safety data in key groups, the emergence of resistance, and treatment failures. Thus, the lack of an ideal acaricide makes the search for novel agents critical. And we all agree with that. We really need to see something new in the scabies treatment landscape. So how can we overcome some of these challenges? Well, one is doing what we're doing today. Education on just scabies as a disease state, recognition of the disease, the clinical lesions, and when to consider the diagnosis, and then how to make the diagnosis, or at least to treat effectively empirically. Second, though, would be the development of novel targeted topical therapies. Remember, targeted therapies are all the rage right now. If we think about diseases such as atopic dermatitis, psoriasis, inflammatory bowel disease, rheumatoid arthritis, lupus, there are many others, we're really seeing them treated with more targeted therapies, which tend to have high efficacy, good safety. They're more targeted to specific molecules or organisms, and they tend to be less prone to the development of resistance. So selectivity is really the key for us to have an agent that has optimal efficacy and safety and is a new therapeutic option. Now, it's important to consider the FDA's newer approach to testing for potential new topical therapeutics. A recent systemic review of randomized trials showed that the existing scabies agents that we have really lack standardization. They may have had low enrollment numbers in the clinical trials. There were risks such as investigator bias. And importantly, we haven't had any newer agents, so they haven't followed the FDA's newer draft guidance to drug makers when they assess the development of topical therapeutics. And these include the things found in the blue box here. Static scales should be used to evaluate cutaneous signs, which may include a variety of things like erythema, edema, papules, erosions. Use patient-recorded outcome measures that are used now in all clinical trials virtually to help assess symptoms. In this case, it might include pruritus, pain, sleep disruption, burning. Plan the timing and frequency of assessments to identify anticipated reactions, and then characterize suspected adverse reactions. And the FDA is very picky now with topical therapeutics that we look for allergic or photoallergic contact dermatitis, which means that during these clinical trials, there has to be specific testing to assess for those types of reactions. So there really is a need for more effective therapies for scabies that would meet the updated FDA's safety and tolerability standards for topical therapeutics. What would be the properties of an ideal targeted topical therapy? So the ideal therapy would recognize a specific target. It would be active primarily at that target site and not just surrounding tissues. It would avoid safety and tolerability issues that may be associated with agents that have to be systemically absorbed, especially those that have potential toxicity, like neurotoxicity we talked about earlier. It would avoid fluctuations in drug levels. It would be such that there was no increased risk for drug resistance. And it would be really agreeable, easy to use, easy to apply, and available to our patients. How about a targeted topical therapy for scabies? What would that look like? Well, we'd want a drug that really has high selectivity for the scabies mite and is highly effective against killing it. One that really, if possible, could stay where we want to apply it, where we want it to have its action and not penetrate into systemic circulation. It'd have to have a good safety and tolerability profile, be convenient to apply, and resistance would hopefully not be a concern. So here's a video cartoon again, looking at the ideal topical agent. It's in white. You would apply it to the skin. It would be specific there, killing the scabies mite specifically. It wouldn't penetrate deep into the skin or penetrate systemic circulation, and instead would remain as a depot on the skin surface where it was sloughed off as we went through the normal process of skin desquamation, as you can see here in the cartoon. So in summary, although we have consensus criteria for the diagnosis of scabies, this disease primarily is diagnosed clinically, and the diagnosis really remains challenging, depending on your experience and your comfort level. There are low rates among some groups of making a correct or at least a timely diagnosis. Disease control for scabies can be difficult to achieve for many reasons, including increasing resistance to the agents we currently have on the market. A new mechanism of action of a targeted topical scabicide would be awesome, could really help meet the new standard for complete cures that we're seeing in clinical trials. Remember, again, there's been no new treatments for scabies for over 30 years that have been approved by the FDA. And a novel targeted therapy could offer selectivity, hopefully efficacy with safety and tolerability balance, and help to combat pathogen resistance. So I thank you very much for your attention. Hope you enjoyed this presentation, and I'll be available for questions.